So now we will have another panel discussion, which will be facilitated by Rita Brown and Sathya Rao. The panel will discuss suicide prevention and BPD looking forward.
I'd like to start off that, like much of today, we're actually talking about some topics that might be fairly distressing for some. So just a reminder to utilise the wellbeing room, step out, whatever you need to be doing. So the panel aims to explore the current and emerging challenges in suicide prevention. However, I'd like to highlight that I am talking beyond just that managing of acute risk to looking at how to maintain a person's overall well-being. So it's more about a sustained relationship-based treatment and care that supports all people to live with the ongoing distress while building hope and safety. So we've got a number of, senior leaders in the sector in front of us, and I'll ask them to introduce themselves in a moment. But Sathya and I hope to spark an open and honest conversation that brings together multiple perspectives of clinical, lived experience and systemic. So Rahul, can I ask you to start by briefly introducing yourself and your role?
Hi guys, it looks like I chose the wrong seat. So I'm Rahul Khanna. I'm the Chief Clinical Officer of SANE. SANE Australia. We're a digital psychosocial provider and do a lot of work in stigma, and I lead our service design team. I've also had the fortune of kind of straddling a couple of parts of the sector, so some of my responses will kind of speak to some of that, which includes a kind of academic institute in the trauma space, Phoenix, Australia, and a public hospital, Austin Health. So yeah, pleasure to be here.
Thank you. Hi everyone, I'm Julian Nesci. I'm a clinical psychologist as my background. I work at Spectrum and as a clinical specialist, which means I'm lucky enough to get to do a whole range of things, like be a clinician, provide secondary consultation to services, do training and supervision and research. So I'll have that hat on, or those hats on, as I think about the questions we've got today.
Thank you. I'm Kate Thwaites. I'm the Deputy Chief Mental Health Nurse in Victoria, and also to Wednesday this week, the Director of the Mental Health Improvement Program, under which one of the recommendations from the Royal Commission 52 around implementing the Zero Suicide Framework in Victoria, and I hope that we're able to talk about some of the initiatives related to that. Encouraged to hear about South Australia as well. Thank you.
Hi everyone, my name's Bronwen. I'm a consumer peer worker at Spectrum, and that's a really interesting role. We do a range of things in that space, including co-facilitating training for the system, and also we work directly with consumers using our service in a peer group and also one-on-one. And I'm really happy to be here.
Hi everyone, I'm Asche. I work at East Melbourne Primary Health Network at the moment as a senior lead in suicide prevention, but my background is predominantly in working with refugees, people seeking asylum, in terms of suicide prevention awareness, and also have a history in some work with complex trauma, and but I've been in the suicide prevention field for about 30 years in different ways, and pleasure to be here.
I'm not going to introduce myself again. You want me to start off with the first question, Rita?
That's what your name is.
Yeah. So, I think let me start by posing this question to both Julian and Rahul. So I think we have touched upon this morning. If you want to elaborate further, if you want to add your voice to this. When you think about suicide prevention in personality disorders, what are the unique challenges that come to your mind? That's first question. And the second part of the question is, how do you think those unique challenges shape the services that we are currently providing, and how could that be changed? So that's sort of the broader theme.
Good questions. We'll see what we think about this. Look, a couple of things come to my mind as far as challenges and then what we can do about them. I notice it's come up a bit today in terms of the accessibility of care. I think that's a huge challenge if we're talking about suicide prevention, not just responding to suicide risk. And one of the things that's been on my mind during some of the other discussions is the private sector. And I think too often we're talking about suicide prevention in public mental health. Of course we should. But from where I sit, there's a whole range of people trying to access care before things get to that point. So I think we need to get ahead of things before we get someone who's in suicidal crisis. As you said before, Sathya, I mean, there's lots of things that we can do to help people before they get to that point. And I think that too often the private sector, we don't have space to do that. And I think one of the things we've seen that we should borrow from is the eating disorders sector has managed to find a model of care that works, I think, very well in the private sector, where people can actually access up to 40 sessions before each calendar year. And I think if we had something similar to that for personality disorder and complex trauma, that might go a long way meeting a need before someone gets to the public mental health system. Maybe one other challenge that comes to mind from my point of view, just to add to some of the things that have been talked about today, I think the other thing we've got to do is find a way to support systems better as well. One of the things that's come up and certainly is on my mind a lot today and in the work that we do is the challenges that systems face, not just at the pointy end of responding to suicide crisis, but in working with people that might present with interpersonal challenges, as someone mentioned today. And I think too often when caseloads are high, when cultures are the way we've talked about today, and there's medical legal risks that people worry about, I think one of the challenges that often happens in this work is curiosity gets foreclosed. I think you mentioned something like that today, Hayley. And I think what we see in systems is thinking gets very polarised, very narrow, very quickly, and things can go into reaction mode. So I think to prevent suicide and to work further in this area, we've got to support systems to be able to slow down and reflect and support them to do that. And of course, education and training is part of that, but we need to make space and support systems to reflect more about these sorts of things. I might pause there.
Thanks, Julian. I think that the thing that comes to mind the most for me is stigma. Like, I think that's just such an enormous barrier still across our service system, and those stories of hope that you shared, Sathya, and those kind of the real stats really around what happens is such an important message to get out there. And I guess the thing connected to stigma is what I like to call risk as excuse, like risk as excuse for non-delivery of services. I get it. I see how it plays out. I mean, if you look at those 8 ambulance admissions, the people at the receiving end never see that trajectory, the more common trajectory of that decreasing over time. So they kind of walk away with this very skewed perception of what life is like and what hope that is there. But that serves as a really big barrier. I guess looking forward, part of what we aim to do at SANE is around sort of that connected care, the non-clinical care that can be universally open, that we're not. We're trying to make clear that maybe the scope of our services are such that they're not the treatment, they're not necessarily the sort of the therapeutic modality, but there's a lot of common needs that a lot of people have, regardless of diagnosis. That if we can kind of connect, if we can empower people to, have that other go, have that faith that, I'm worthy of care, that I can seek it, again, even if, my attempt at 4 a.m. last night didn't get the response that I needed, I'm still deserving of giving that another go in the light of day. So those are some of the things that kind of, give me some hope, and hopefully it's a path forward.
Thank you. One follow-up question for you, Julian. You mentioned about supporting the system. Leaving aside what Spectrum does in Victoria, how can who can support the system, and what sort of supports can be offered to the system, and by who can do it?
Well, that's a big question, but a good one as well. I might have some thoughts, but maybe not the whole answer to that. But I think maybe borrowing from some of the ideas we've already talked about, how sometimes this field becomes seen as a specialist thing that only specialists can do. I think the sorts of things we can do to support systems don't have to be necessarily specialist things. For example, we can have medical legal support. We can have lower caseloads so people can actually have time to not be in reaction mode. We can instill cultures where teams actually have reflective spaces rather than just spaces where there's a strong pull for people to know and be experts and to have to fix and come up with answers. Of course, that's got a role, but I think just small changes like having a culture where it's actually safe to reflect and table different thoughts and to bring those thoughts together rather than the siloed sort of situations we can see in various teams and systems. So I think there's small cultural changes that can have a big impact in that area.
With your permission, can I pick Bryn's brain on this, given that he's here? But the question is, are there really any unique challenges? Are there things unique to personality disorders which is challenging? Or are there really generic challenges for the entire mental health sector, entire health sector? Because we tend to, of course, because we work in personality disorder, we tend to think that the challenges are unique. Now I'm just trying to unpack. Do you think there are really unique challenges, or are they generic challenges?
Generic.
Thank you.
Is that the long or the short answer?
Thank you. Anybody else on the panel want to
Oh, I'd
add
actually
to
like
this?
to add to that, Sathya, in that I think it's really important that carers get the education and support too. You know, for families, the distress is often built up for a considerable period of time. The person goes to ED, maybe gets virtually set straight home, but we're still in a highly anxious and agitated state. So giving us some skills so that we can actually manage those situations better, I think may actually help to escalate some of these crises from even reaching the stage that, you know, an intervention is required. And I'd also like to add to that in that I know that clinicians sometimes feel that carers should just do something or other. However, the reality is that most of us are actually in what I'll call survival mode, and we're actually doing the best that we can at that moment, and just do something else is just not on our radar.
Thank you.
So I'll move over to Bron. Oh, actually, you better get Sathya's mic. Thank you. So, Bron, from a lived experience perspective, I think what has made a difference for you to help you feel safe and supported during times of crisis? Because I think that this is really the message that this room needs to hear. We all have the best intentions to be doing our best, but unless we actually know what works, and acknowledging that it's probably different for each person, but for you to give us a little bit of an idea about that.
Yeah, sure. I mean, yeah, I was getting ready for a training a little while ago and actually asked this question to our peer group. And our peer group is made of people that are waiting for treatment with our service. So they all have a diagnosis of either complex trauma or personality disorder or both. And I just wanted to read some of their responses and then maybe talk a little bit about it. So the things they highlighted as helpful were being met with understanding and patience rather than a sense of blame, having the intensity of our experience validated, giving consumers the time and space to work through something intense, knowing that practitioners won't take it personally and will stick around. Service providers holding the belief that the consumer can get through, as the consumer themselves might not have access to that. Not taking self-harm as evidence that the consumer is failing or that the therapeutic process is failing. A genuine connection with a service provider is in and of itself helpful. And when the agency of and independence of the consumer is respected, that's really important to people. And things that people felt were unhelpful were the sense that they weren't being listened to or understood in a healthcare setting, feeling shut down by the service provider, feeling judged or blamed, having a solution forced on them, getting the sense that they weren't getting access to the service because of their diagnosis, or not having their experience taken seriously. And I'm thinking about, when I think about that stuff, I really think about, the wages of stigma. I read a study a little while ago that was recent, it was from 2023, and it talked about narratives in healthcare settings and how they impact quality of care. So thinking about how do we talk about BPD in healthcare settings, or how do we talk about an individual with that diagnosis in a moment like a handover, what language is used in the handover. So the study found that, yes, it's a thing, and stigma is alive and well, and it definitely impacts the way people are able to access treatment, and it can also potentially exacerbate whatever the problem is that the person's managing, and they're kind of sent back out there into the wilderness. And like I was talking a little while ago to a consumer who said, because as Megan said so beautifully earlier, validation, I think, is so central. And I think the sort of, I'm also so interested in what Hayley was talking about around, our function, and the fact that people with this kind of diagnosis have been shown to have an overactive amygdala, which you guys may all know. So we have functional and structural changes to the brain, and that will be borne out in behaviour. It means that we're more likely to reach a heightened emotional state, and also potentially more likely to stay there for longer. And because of neuroplasticity, we can retrain our brains. So I want to tell you guys that. I feel like I'm preaching to the converted, and I think the project is, how do we tell everybody in the whole state that that's the case? That just like when you have an overactive thyroid, it has a behavioural sort of thing that comes out. So with this diagnosis, and that it's treatable, and that we have neuroplasticity, and we can, adjust or learn to manage things in a different way. Yeah. Does that answer the question?
It does. Thank you. I'm just wondering if anyone has a comment that they would like to add to what Bron said.
Thanks. Bron, I completely agree with you, and I'm not speaking from lived experience of complex trauma, so to speak, but in the 90s, there were about 10 years that I had the privilege of working with young people with child sexual abuse histories who were considered the highest risk in the state. And to be honest, I had no skills whatsoever back then, but just being able to sit with them, give them the space to listen, to literally work with them long term over 3 years. And we had that privilege, and to have a very small number of people we worked with, so we only worked with 4 young people intensively. And I think these are the sorts of, those sort of testimonies indicate this is the sort of model that we need to come back to. Now, again, we were very fortunate that we only lost 1 young person throughout that 10 years. That was 1 person too many. However, I think we've lost the focus on actually just compassionate care in that way. So, yeah.
Could I add something? One of the things that the study showed actually was that training in and of itself doesn't necessarily shift narratives around BPD in services, and what is required is culture shifts. So, as Julian said, space to reflect and potentially support, I guess, in addition to training and understanding, sort of systemically what might be happening for a person if they're presenting in a certain way.
I think part of that changing the system is also changing the way that funding is sometimes allocated, and that's a huge thing. But to have as part of the KPIs for clinicians the ability to have time to reflect, because I think that is so essential to help keep you in a compassionate place in this space. Okay.
Thank you. Thank you, Rita. I absolutely agree. And some of the frameworks that the Chief Mental Health Nurse and we've been delivering in SaferCare Victoria include Safe Wards, which is a framework and a model of care that talks about positive words, and it's a cultural shift. We're actually rolling that out across whole of health now and through emergency departments. So what we're doing is supporting people with the model and the interventions, and they're choosing them from different interventions for the emergency department, but it provides people with a capability around responding to people's distress and thinking about it in a different way. And certainly from your suggestion, positive words. Use positivity when you're talking about people. Be hopeful and aspirational about their hopes and dreams and what your role is engaging them in that. The other thing I was thinking about was the restorative and just culture work that's been referred to already today, and how you think about safety cultures and reporting cultures in health systems. And that's some of the work we're doing in the Zero Suicide Framework, is to embed that culturally. So a systemic approach to thinking about the context in which you're asking people to come to service, but also asking your workforce to practice in.
Ellie, this one's got your name on it. So, working in a primary health network, at a systems level, what do you think gets in the way of providing timely, compassionate and appropriate support living for people living with BPD who are at risk of suicide? And then the next part is for their carers.
I'm going to turn that round a little bit and say what is actually supportive, in a sense, for people. I think, again, and it is around the sorts of models where we've got longer-term support, where there is the capacity, as it's already been said on a number of occasions, where we've got space to reflect, we've got space to truly be there with people. I think from a systems level, one of the great initiatives that's come through from a suicide prevention lens anyway, has been these roles which have got systemic oversight over a particular place-based area. And what that allows is for us to do that sort of innovative work to address areas which are, such as support for people living with BPD or complex trauma. And it enables us to direct funding where those gaps are systemically. So, for example, we've got a couple at the moment where we're socialising the entire catchment with a lived experience of suicide lens. So we're providing support for both clinicians as well as people with lived experience who may not identify as yet as having a role in the system, workplaces to hold a peer work system. So I think where PHNs, if you want to speak at it from that perspective, they can take that neutral space in the systems oversight, so that they can then also look to promote and support innovation where hasn't been before. So that's from a broader perspective. I'd also just like to say that from a hopeful perspective, there's a lot happening in suicide prevention field, which is incredibly, wonderful to see. If I think back over the last couple of decades, we've never seen a time like this. We've never seen a time when there's been such a dedicated focus on, supporting people at risk of suicide, and that's across the spectrum of all needs. You've now got both strategies, a Victorian strategy and national strategy. You've got suicide prevention officers set up at the state level, at the national level. There's also been a narrative shift, which still holds a health lens. Of course, we've got to have both, but to refocus on social determinants of what is actually happening for people. And when you talk about trauma, that is one of the biggest areas that is currently being focused on, and where that connection is with suicidal distress. There's a lot of innovation occurring. There's the safe spaces, the peer care companion warm lines where someone can ring up and speak to a peer. So I think there is a time for us to be hopeful as well, and to, we are heading in the right direction, and it's going to be, it's not quick, as we know, but I think, there's time to celebrate at the moment as well, and to keep that momentum going. So.
I just wondered if, off the cuff question, if you just wanted to mention a little bit about what Roses in the Ocean is doing about using that peer lens.
Yeah, so that's the lived experience capability building that we're rolling out across the catchment, and that is for both allied health clinicians as well as peer support workers, as well as those who have a lived experience of suicide themselves, whether that's bereaved, a living experience of living with suicidal ideation or thoughts, or having had attempts. And it's just basically to provide that a suicide prevention lens alongside a mental health lens. We do need both, and we need to bring the two together because they both complement each other. But there is something quite distinct about a suicide prevention lens, which is different to a mental health lens. And I think one of the key there is that with a suicide prevention lens, the focus is predominantly on, you know, the causation, the contributing factors, and that's where the suicide prevention lens has gone, as opposed to a symptomatic focus, which has tended to be how suicidal distress has been treated within a clinical lens or clinical settings. And there's no judgment on that, but it's just a different lens, and we are now understanding that at least 50% of people don't have a diagnosable mental illness. They may have trauma, they may have underlying social determinants which have led to the suicidal distress. So we have to pivot a little bit as well with that.
So, thank you. Moving on to the next question. This is a question we'll start with Rahul, but I would like the entire panel to comment. There's a fine line between trying to help the person stay safe and alive and using much more coercive practices and taking away their autonomy. Do you have any thoughts about how can clinicians, systems, and even families can negotiate that space?
Yeah, the easy ones. Look, I think it does come down in part to some of the things Julian's already mentioned around creating some reflective space, realizing that, you know, even from minute to minute, and certainly hour to hour, some of these conversations need to be revisited. You know, they're not static and set and forget. And unfortunately, often we're not resourced to have those conversations and repeat them with the frequency that's required. But I think that's part of the answer. We recently, with my other hat, Phoenix, released some trauma-informed practice toolkits, and we're kind of doing soft launches of it. But one of the things that we're trying to weave in there is how we work in, again, similar to the Safe Words commentary, on different opportunities to kind of reflect on trauma, so flashcards and how they get woven into meetings, reflective supervision, etc., to keep that type of dialogue active. And I suppose there is, I guess, more to be done with clinicians thinking about that medium term, you know, even, and sometimes in these scenarios, medium term can just be tomorrow, you know, like how are your discussions, even if the action is the same, how's the frame and the way you're engaging with a person going to be conducive to when circumstances change and when that person might want to reach out next time for support.
Rahul, I'm going to ask you a follow-up question, if you don't mind. Sure. Noting that you represent the next generation of mental health leadership, when we are walking that fine line, we know that the science doesn't help. There are no risk assessment magical tools which tells us clearly what to do, what not to do. And even in our space, in our field, we know that people with personality disorders, often they're not able to really tell us. They themselves don't know often whether they're suicidal or not. Because this ambivalence kicks in from what we understand. So given that everybody's negotiating such a fine line, things can go wrong. Yeah. Right? So, and then the system we have right now is often not supportive of clinicians making those decisions, and decisions can go wrong, and that can drive the risk-averse culture, right? And any amount of teaching and training you do doesn't help there, because at the end of the day, that person thinks that I don't want to be the last person to have made that call. And I'm interested. See that it's a huge question. None of us probably have answers. Being one of the upcoming leaders, I'm interested in your perspective of how do you think we can negotiate this and what we need to be doing?
Yeah. So I often draw to, I contacted a mentor a few years ago when I was considering going for a leadership role that was quite early in my career. I said, "Look, what do you think? It's been vacant for a little while. I would have ideally waited a bit longer, you know." And he said to me, "Look, Rahul, that no matter how complicated a problem gets, generally the moves you've got available to make are not very many, right? 2, 3, maybe. So as long as you can satisfy yourself that you've given yourself a few minutes to think about what those 2 or 3 options are, and can say, you know, in the end, I did the best I could with, you know, with what I knew at the time and what I saw in front of me, then so that's enough." And I guess another mentor once said to me, you know, he often thinks about the pillow test. Could I put my head on the pillow tonight, you know, and if I can't, maybe you know, that's the moment where I need to call someone or a colleague and kind of talk it through. So I suppose I try and channel a few of those, because, you know, often there aren't good options on the table.
Thanks. All right, so coming back to the question about autonomy and so on, I mean, one of the things going through my head is, first of all, obviously that's a challenging thing to do, isn't it? There's not sort of an easy just do this or just do that. One of the things that's been on my mind across the day is, you know, we've got the tension between the diagnosis and the person, and for me that comes into this equation as well. You know, there's not just an easy playbook. If someone's got borderline personality disorder or complex trauma, just do X. And I think it's quite dangerous if we sort of go down that territory in a way. So I think one of the things that can help us in terms of managing this tricky question of where's the right line to sort of draw in terms of autonomy is really obviously having space, like I've mentioned, but really taking a formulation-based approach where we look at, for this particular person, what we know about them, their life, not just now and what's driving the stresses, but their life, how they've managed that, how their experiences have shaped their behaviour, these sorts of things. How does that help us think about what to do here? Not just in the short term about managing autonomy, because that then, and there is a tension there, isn't there? We've got to be able to put our head on the pillow at night, but also in the long run, you know, because if we just think short term, then we can make some very understandable decisions, but sometimes these decisions don't necessarily help the growth that we're trying to help develop in someone as well. So I think it's a really tricky tension, but we need to take a formulation-based approach. And again, I think we need to guard against our thinking getting polarized around these sorts of things. You know, for any of us, when we're under stress, emotions can cloud our thinking, and we can get very sure rather than curious, and we can get very sure that admissions are never indicated or only an admission will save someone's life. And I think if we're thinking about these sorts of things, we've got to be able to slow down and work out if an admission is indicated, in what way might it help this particular person? How do we know if it's helping? How would we know if it wasn't helping? So we've got to wind back our certainty and really think these sorts of things through for each particular person.
I would be really, if you don't mind me being a bit cheeky here, is it, would it be, how can the lead organizations like SaferCare Victoria can help us clinicians make those kind of, I'm not asking about guidelines, you know, the system being, you know, more tolerant of the clinicians making those sort of very fine decisions and things going wrong.
Thanks, Sathya. I think understanding the role of SaferCare Victoria, and it's a safety and quality agency, it also has clinical chiefs, so chief mental health nurse, myself, deputy chief medical officers, paramedicine, nurse and midwife. So all of those workforces come together to describe the clinical practice and to support workforces out in the sector. So I think that's a great understanding of what's possible from a workforce perspective. Also rolling out the work that we're doing in the mental health improvement program and describing what that could look like as the Commission asked us to, and how to do the work in the way the Commission asked us to. So there's principles around that we find are central, which includes lived experience being central to everything you do, co-design, co-create. And the Zero Suicide Framework rollout is the same. It's about systemic change and cultural change and providing workforces that have been doing this good work for a long time with contemporary ways of thinking differently and supporting them to do the work they would like to do differently. And what does that mean? It means creating and challenging our organisations around risk assessment and risk mitigation. It looks like changing from stratification to formulation when we're thinking about risk. It's about human-to-human relational connection and saying that's a priority for our system. And I think once we can assure our workforces that we have their back, that this is the way we would support them to practice and create policies that support that as well, such as just and restorative culture frameworks, then we'll be a long way to go forward. And we've got the indications from the Royal Commission in Victoria that help us with that thinking. And I think we need to hold the hope that we're just starting on a reform journey, and that we have to hold the hope because the people we serve and their families are doing it much harder than we are. So we actually have to hold that hope and use the system around us and the people who we serve and their families as the compass for that work.
Thank you. Thank you. Bron, do you have any thoughts about how can clinicians negotiate that fine line?
Well, I guess I'm just in listening to this conversation, like I'm thinking about when I was managing, chronic suicidal distress and self-harm. Nothing that anybody said would have stopped me from doing, particularly around self-harm. Nothing that anybody directly said, don't do that or try this instead. Like that wouldn't have stopped me. It didn't stop me. And what actually did make a difference, as Kate just highlighted, was the kind of spaces that I was in, and was there connection? Was I validated? And I guess I've been thinking about the alt to SUI approach, which is a peer-led space where you're able to kind of talk about what's going on, and there's not this question of risk assessment or will something be sort of escalated? And there is emerging research around it showing that it's effective, and I guess I share that because it really resonates with me. That makes a lot of sense to me in terms of my lived experience. That connection and validation feel very central to navigating those tricky spaces.
Just following on from that, I completely agree. I think, and that's a wonderful thing about where the field's heading, because there are a lot more of those spaces where it's about relational support, not transactional. It's where some of the safe spaces, for example, that are, and there's a myriad of them, but some of them you don't even have to give any indication of your name, your background or anything. You walk in without any identification as such, and you're able to just be there and speak with people who are peers. And I think they're really fundamental additional, models of support that we need. And there's thousands of testimonies now about people in suicidal distress, what they need. And they're the voices that we honestly need to have absolutely central to everything we do.
Sorry, just one final point on this. I think one of the things that I've been reflecting a lot on as someone who works in both a kind of hospital, a very medical setting, and a much more lived experience, community-led organisation where 84% of the SANE staff members identify with a lived experience. There's really something to be said as well for how the two sectors can seamlessly work together. Some of these models just work without the doctors in the room, right? Like needing to be there, because then you've got a whole entities of thousands of people that are used to a particular way, a particular approach to corporate governance, to clinical governance, etc. And moving that is very hard. But I think too often the sectors are seen as kind of convenient ways of saving costs, rather than thinking about, where can this work happen best and most effectively and impactfully, and how can that then connect to the clinical space. So that's certainly on my wish list as well.
just have a quick off-the-cuff question? And it was a question asked in an earlier session. We didn't get round to answering it, but I felt it was relevant to this. What role do you think insurers actually play in increasing the level of adversity to risk? So, Rahul, you look like you're going to say something.
Look, I had the interesting fortune of in one of my roles working quite closely with a non-profit health insurer who's funded a few bits and pieces of what we do at Phoenix, including a psychiatry clinic for around trauma, as well as a kind of more recent large research project. And it's through that interaction, and it's Latrobe Health Services, through that interaction I've discovered how hamstrung they are in funding innovation. Like, the legislation is really quite prescriptive about what they can and can't offer. And my relationship with them really began a few years ago, where they said, look, Rahul, we really care about mental health, but as the cheapest provider of a gold sort of plan, anytime someone tries to access private mental health admission, the hospital tells them to sign up to us and we'll go bankrupt, right, basically. So, what can we do? We, in fact, actually can't fund much without, like they basically, the only way to kind of fund an innovative program is to kind of make it an extra offer or a bonus. If you get an extra cover and hospital cover, then we'll chuck in a, insert project here approach. And so I think there's both the insurers level, but also how the regulation and governments work. And I guess with all the kind of drama around sort of some of the private hospitals, one of the things that they were saying is that in some of that dialogue, there's this, I guess, misperception that a lot of what looks like, just corporate spend is actually just a reflection of our reporting rules. So when they support, my clinic, for example, that goes up as in the same bucket as their corporate costs. And so they get painted as a villain, but a lot of those are actually kind of them trying to kind of move the needle in innovative ways of kind of working.
Thanks. It's a great question. The hospital insurers did partner with us to roll out safe wards in mental health, in fact. So they do have promotion arms that they're really wanting to reduce premiums, and they do try and partner, in our experience, to support that. So that's the experience over probably 3 or 4 years of funding with the Safe Wards program. Can I just add something else around training? We do have new training up on mental health professional online development, so MHPod, which is available to everyone. And it's newly supported training for all of healthcare, and as someone said before, accessibility to everyone that people may come across in a health service is really important. So including healthcare training for clinical, non-clinical and lived experience workforces around suicide prevention, because it's not necessarily something that's been there before. So our project lead mapped who had suicide prevention training, and lived experience workforce did not. They looked at suicide training as well. So I think it's really important to try and get behind that mapping of the training and thinking about what workforces said they needed. So I just wanted to give a little shout out for that as well.
You can keep holding the mic unless someone wants to answer my question.
Can I say something about training? Is that okay? Yes. Sorry, Rita, I just wanted to say something about the training side of things. I think that sounds a terrific venture. We're often involved in a lot of training at Spectrum, and one of the things I think there's a little bit of a gap about is we see a lot of enthusiastic clinicians come and make space in their mind to do the training and then get energized to go back to their services to do the various trainings. And I think one of the challenges is when there's not a care pathway at their local service where someone can put the things into place, the enthusiasm quickly goes down, and often clinicians get jaded. They get very excited and passionate and then can't put the skills they're learning into play. And that's a problem for the people who are supposed to be receiving the skills, let alone retaining staff and enthusiasm. So I think whatever training strategy we've got, we need to sort of support its implementation beyond the training days. So, sorry to hijack.
It's okay, you can give it to Kate now. Back to Kate. Thanks Julian. So, Kate, looking forward, if we want to truly reduce suicide-related deaths among people with BPD and complex trauma, what are the most important shifts in policy, services, research or community attitudes that we need to see? I think you've sort of touched a little bit on it, but do you have anything that you'd like to add?
It's a lovely question. Thank you. I would always go back to human connection and kindness and compassion for each other and for the people who come to service and their families. So for me, the immense skill and support that workforce bring to the work that they're doing is enormously helpful. That compassion is what people often will say to us. They remember how they were treated. And so for me, if we can scaffold that with a system of support, such as the Zero Suicide Framework and the restorative culture, just and restorative culture that wrap around a workforce, as well as good clinical supervision that support and nourish your workforce, then we've got to, if we've done that very fulsomely across our workforce and our health service, if we've had good training that's in context of the systemic changes of Zero Suicide Framework, for instance, so you've got organisational support at every level from board down, so you've got people that know that you're going to support them as they're applying dignity of risk or other things to people's self actualisation around their own care decisions, and that the staff are supported whatever happens with the work that they're doing, and that they have safe spaces to reflect on the impact of their work on them. And I don't think anyone that I've ever worked with goes to work for something to go wrong. And that will stay with people for the rest of their lives, a ripple effect, as we all know. So I just think that the self-kindness and compassion to each other will allow us to be a more compassionate, responsive community wherever we might find people. And I think the Zero Suicide Framework suggests that it's not clinical staff's responsibility only, it's all of us as a community. And I think that for me, if we could ripple that out and say, let's create the conversation so that people feel comfortable having that conversation in the "are you okay" sort of way, all of those things about what do we bring to each other, and being okay with that, I think that would be my suggestion, Rita.
So I'll once again hop on my hobby horse of being a carer. So carers actually need to have that understanding as well. Yeah. As a mum, your autopilot when they're little is you problem solve, and gradually you have to let go of the problem solving, no matter how unhelpful you think the action is. So some education and support for carers.
Absolutely. People and their families, carers and supporters. And I think that the needs of carers can be different and need to be seen in their own light as well. Thank you. Thanks, Rita.
Sathya?
Rita, given that we only have one more question to go and 15 minutes left, the discussion about what sort of policy drivers we could utilize or think about this work, could we tap into the wisdom of the audience as well? I'm particularly interested in, sorry to put you on the spot, Peggy and Bryn's ideas, as well as anyone else in the group.
Sorry, who start with Bryn? I'll start with Bryn. Did you put your hand up? I think you got dubbed in though.
So you're asking, Sathya, in terms of the around suicide prevention. Look, I think there's probably many things that we can draw on. I mean, I think the statistics are compelling. I think the impact in terms of, families and communities and, if you want to get into the productivity kind of line, I think that if you want to look at the broader systems things. I was just having a conversation with someone before lunch. You know, in Queensland, we have this kind of focus on, and it's not just Queensland, focus on youth crime and, you know, whatever. If you want to actually tackle youth justice issues, tackle the problem, not the, you know, blame the individual. So we've got things potentially in our toolbox that will help reduce suicide, which will actually also help reduce some of these other issues as well. And we will help the workforce who are dealing with those complex issues more broadly, if we can just give them a little toolkit. They don't have to be clinicians, but to know how to work with it. So I think in terms of policy levers, it's about, you know, the numbers, it's about the moral imperative, it's about the causes and the potential benefits of actually tackling this in a really systematic way. And that emphasises the care and compassion, which is absolutely central to success. It's about respecting human dignity, human rights, and, you know, that should be a compelling argument.
Any other comments, questions? Good on you, Hayley.
So when I was a student nurse, I had a tour around the place that I was going to do my placement. And the lady took me around and she said, we've taken down all of the possible ligature points all over this place. And in that moment, I had what I can only describe as heart drop. I was like, oh, you prevent suicide by frustrating people's attempts to end their life, not by making them want to live. And I think I'm just underscoring what Peggy's just said, really, which is, how do we help people build the life that they want to stay alive in? And that does involve looking at social justice. It does involve looking at the unfairness that's within our system and beyond our system. And unless there is an actual willingness to address the social justice, then we're spinning our wheels trying to change the icing on the cake without looking at the recipe. And that's my passionate thing that I talk about. So I'll stop now. Thank you.
Thanks, Hayley.
Just listening to everything, as someone who's gone through the medical model and found peer work near the end, and obviously now do the peer work, that holistic approach of looking at models that are outside the medical model, that aren't the clinical doctor. You know, I don't know if anyone's heard of Left Right Hook. It's a boxing and creative writing program for people that have gone through trauma. It's an amazing program. You know, you've got, you know, the benefits of the brain that Bron ran an absolutely amazing lesson on Wednesday at Spectrum on the effects that gratitude has on the brain and mindfulness and meditation. And we had a great yoga thing. And, you know, the feedback from that was it needs to be offered more. So those kind of aspects, to me, scream out too.
Thanks, Ruth. And I think it's really important that these could potentially be offered in the community. It doesn't have to be by a specialist mental health service.
Absolutely. And if I could just say that one of the hats I wear is chair of the board of Mental Health Australia, and in wherever forum I get the opportunity, I make the point of saying that, you know, to have an efficient and an effective, well-balanced mental health system, you need to put the non-clinical with the clinical. And, you know, too much of the emphasis and, quite frankly, the majority of the dollars go on the clinical side. And I'm not wanting to take away from the clinical side. We need some clinical services, but we need the other as well. And we need to build up that. It's probably where I differ a little bit from Sathya. I still think we need some additional resources to do some of that. But acknowledging what Sathya says, we've got a lot of resources we could use a lot better. But let's also build up the things that we know have an impact and that actually what people want.
Well,
Okay, don't get me wrong. I'm not saying that we don't want money. I spent 25 years asking for money, which has not come through. Now I'm trying to see what we can do within what we have got.
sorry, I'm not too sure what time this panel's supposed to finish. 3 o'clock. Okay, I don't have to rush.
Just
then.
wanted to make a comment on a couple of things in relation to social justice. Number one, in that if we look at what the National Suicide Prevention Strategy looks at, it is around social determinants. So the whole, sort of way that we're heading is around addressing social justice principles. And I think that's absolutely wonderful. The other thing would be around another area of advocacy is where over the last couple of years, there's been a suicide prevention planning model developed, which is for funders, basically, for funding bodies. And I would have to say that in the very beginning, it was going to be potentially, sort of implemented or integrated within the mental health model, which is fine. We need the integration, but we also need a separate suicide prevention planning model, which is what was developed. And I think having the courage, you had all the peak bodies sitting around that table in the development of that particular planning model. And what I'm incredibly grateful was that they listened to the point of we can't go with the status quo. We need to plan for a model which is going to be 10 years down the track, where we actually have the infrastructure in place to address and support people in suicidal distress right across the continuum, in terms of trauma, in terms of BPD, in terms of men, and the whole, right across the gamut of those who are at disproportionate risk. So, it's about also, I think, standing up and being prepared to advocate and hold the space too. And I think lived experience obviously is core to that. So.
Thank you. I move on to the last question. The last question is about hospitalization.
Yep.
So given that 20% of the public hospital beds are usually used by people with personality disorder, that's a common statistics. And if only the money which we spent on beds could be utilized for treatments in the community, we would be doing a very different job. So given that there is really, we're not going to do any magic psychotherapy or psychological treatments in the inpatient setting, are there any alternatives in terms of instead of hospitalization, which you could think of? And that also goes into the question which Haley was raising. Again, there's a fine line. Ligature points, yes, that's a different focus, but when people are in crisis, what do you do? That's a question for us. It's a dilemma.
Yeah, so look, I've got two perspectives on this. One is that a lot of my clinical work has been with veterans, defence veterans and first responders. And look, a substantial proportion of that, even though it's, often it's considered different, a good 84% of treatment-seeking veterans actually have complex PTSD or indeed borderline personality disorder, and I work in an inpatient setting, and many of those actually get a lot of benefit. But what's different is that it's a kind of standalone building, it's unlocked, it's and the frame is non-stigmatizing because everyone feels that they've had, not entirely non-stigmatizing, but much less stigmatizing. So I think it's not necessarily true that, inpatient facilities don't have a role. The reality is that publicly funded inpatient settings, of the brevity that we've got, of the structure we've got, of the mixed nature that we've got, don't necessarily have much of a role. So I think, there's probably that distinguishing that needs to be, I think better understood, not that, and I guess less black and white. But I think that there are plenty of models, and I think I'm, heartened that we're seeing more and more of them. So things like the hospital in the home programs, things like, other step down, step up, and to Rita's point, how do we best empower carers as well to make some of these decisions and be part of them, and in the dialogue of the various trade-offs that perhaps the clinician might be making as well indeed, in bringing that compassionate lens to working through that, and also kind of sometimes it's we set up our services such that it's a problem to change your mind as well. Like if someone comes in on a Friday night and there's been these discussions, and finally, unfortunately through either sort of coercive action or employing the Mental Health Act, the person has ended up in a hospital. Now that person can now not leave till whatever fires have been put out, and they're able to be seen. Oh, I've only got 1 minute, so I'll wrap up. But how we best kind of unblock that, and think of whether telehealth, whether there's other pathways that we can support, so that when things have changed, that is actually truly the least duration that people could. Sorry.
I'll try and speak fast so that the others can have a turn. Okay, look, in brief, I don't think I've completely given up on inpatient units. I mean, I think, Hayley, your comment and Bron, some of the stuff you're talking about that people told you that felt useful, I think maybe we need to think about if in those settings, maybe it's less about doing to and more about how we create a space where someone can be and feel heard. And there's a sort of a culture shift around that. Having said that, I mean, there's a limit to how much, if you're ending up in a hospital, that's not a great situation to begin with. So how can we sort of create better step-up pathways? I think we need to keep looking at the step-up pathways like PARC and seeing how much we can increase the funding around that and support. I think we need a parallel pathway to ED. I was in ED in winter for a completely different reason. All the seats were taken, standing room only. That was disappearing. The line was 30 people long. Everyone was doing their best. That was not a place where validation was going to happen for all sorts of reasons. So we need a different inroad in those sort of situations. So.
Thank you. Safe, timely, effective care, I think, in the context where someone chooses that care would be wonderful, and with a capable, nourished workforce that look forward to supporting people and their families and carers.
Yeah, I agree. And I think I'm thinking about like escalating the voice of the consumer in all this, and because I think there's a lot of robust advocacy about reducing restrictive practices, but what I hear a lot from consumers is that they wanted to access a service and they couldn't. So I'm thinking about that.
Again, just coming back to the alternatives, I think to emergency, which it's very clear we're all on the same page on that one. So anything that we can look to support the development of, similar to the safe spaces and so on.
So just to remind that there are times when hospitalization can be life-saving. So we shouldn't miss that part. Routine hospitalization is what we are talking about, where it is less useful. Rita, do you want to wind down?
I'd just like to thank everybody for their participation today. It's been really appreciated. I think we've had some robust conversations, and hopefully we can drive this forward. I'd just like to give each of you a small gift, plus a little motivational toy. It's not really a toy, it's an animal that's got a really positive message, and I'd like to thank Ruth for creating those